Welcome to Critical Care Code, your fast track to mastering ICU essentials. In today's high-stakes session, we're diving deep into skin and soft tissue infections, from erysipelas to necrotizing fasciitis and gas gangrene. You'll learn how to spot them, treat them, and save lives when every second counts. Let's decode critical care, one case at a time.
Welcome to Critical Care Code. In this session, we will cover skin and soft tissue infections, a topic of major importance in clinical and intensive care practice. We will review definitions, types, classifications, risk factors, clinical features, diagnostics, and therapeutic strategies. Let's begin. Skin and soft tissue infections. Definition: bacterial infection of the skin, epidermis, dermis, subcutaneous, skin appendages and muscles, including fascia. Especially gram-positive bacteria, like streptococci, especially Streptococcus pyogenes, beta-hemolytic streptococcus of Lancefield Group A, Staphylococci clostridia. Frequently polymicrobial, mortality of complicated cases about 30%. Guidelines. Practice Guidelines for the Diagnosis and Management of Skin and Soft Tissue Infections 2014 from Infectious Diseases Society of America. Types: erysipelas, phlegmon, necrotizing fasciitis, special form Fournier gangrene. Classification: according to urgency, according to Kingston. Mild infection, slow progressive, conservative treatment. For example, erysipelas, furunculosis, impetigo. Moderate infection, urgently surgical treatment. For example, abscess, phlegmon, infected diabetic foot. Severe infection, rapidly progressive, immediately surgical treatment. For example, necrotizing fasciitis, gas gangrene. According to Food and Drug Administration, uncomplicated, complicated skin and soft tissue infection, deeper tissue layers affected, fascia, musculature, severe underlying disease, for example, bacteremia, diabetes mellitus, steroid therapy, liver cirrhosis, child B and C, neutropenia, organ transplantation, immunosuppression, alcoholism, malnutrition. According to Infectious Diseases Society of America. Purulent, boils, carbuncles, abscesses. Non-purulent skin and soft tissue infection, erysipelas, phlegmon, necrotizing fasciitis. Risk factors: skin lesion, surgical wound, for example, necrotizing fasciitis of the abdominal wall after cesarean section. Edema, especially lymphedema. Chronic venous insufficiency, peripheral artery disease, diabetes mellitus, immunosuppression, obesity, malnutrition, alcohol and drug abuse. Symptoms: extreme local pain. Microthromboses of the vessels lead to ischemia of the fascia. Pain out of proportion, erythema, possibly bleeding, blistering, bully, edema. Diagnosis: clinical examination. Laboratory, for example, rising leukocytes, CRP, procalcitonin, creatine kinase. Imaging, especially to evaluate the depth of infection. Sonography, CT and MRI, the most sensitive imaging. If necessary, biopsy in uncertain cases. Therapy, conservative. Surgical, first conservative therapy. Antibiotics. Wound treatment, phase adapted. Initially keep moist, hydrocolloid dressings, possibly vacuum-assisted closure. Sepsis therapy, if necessary, hyperbaric oxygen therapy. Cefuroxime or ceftriaxone plus metronidazole. Piperacillin plus tazobactam. Carbapenems, meropenem, imipenem. MRSA linezolid, means of choice. Daptomycin, tigecycline, tetazolid, vancomycin plus rifampicin. Second, surgical therapy. Debridement, early and radical, programmed redebridement after approximately 24 hours. Amputation if necessary, usually the only life-saving measure in gas gangrene. Erysipelas. Definition: acute bacterial, non-purulent infection of the skin without involvement of the subcutaneous, I mean limited to the epidermis and dermis, in contrast to phlegmon, here with involvement of the subcutaneous. Bacteria, Streptococcus group A, beta-hemolyzing. Staphylococci is rare. First portal of entry, then spread via the lymphatic vessels. Predilection points, lower leg, most common, minus face. Predisposition. Lymphedema, erysipelas are the most common complications of lymphedema. Erysipelas are also a frequent cause of lymphedema. Obesity, chronic venous insufficiency. Peripheral artery disease. Dermatoses, tinea pedis. Symptoms, sharply circumscribed, phlegmon, blurred redness, overheated, painful, possibly regional lymphadenitis. Fever, therapy, antibiotics. Penicillin. G, means of choice, 3 times 10 million units per day, intravenous route. In case of renal insufficiency, creatinine more than 2 milligram per deciliter, 3 times 5 million units per day, possibly continuously via infusion pump. Cefotaxime, clafuran, clindamycin in case of penicillin allergy. Immobilization, cooling and dressing. Treatment of the portal of entry, for example, antifungal therapy for tinea pedis. In case of frequent relapses, prophylaxis with long-term penicillin.
Necrotizing fasciitis. Definition: bacterial infection of the fascia with consecutive necrosis of the cutaneous or subcutaneous. Course: fulminant, destructive. Mostly fascia of the extremities affected. Mostly lower extremity affected. Most common pathogen: Streptococcus, group A. Most common severe soft and skin tissue infection, mostly severe sepsis. Mortality: 33%, one of the few dermatological emergencies. Types, according to Giuliano. Type 1, 80%, polymicrobial, mixed infection. Type 2, 20%, monomicrobial, group A Streptococcus, var hemolytic. Type 3, very rare. Due to vibrios, for example, Vibrio vulnificus after contact with seawater or seafood in the Baltic Sea. Type 4, very rare. Caused by fungi. Aspergillus, candida, usually post-traumatic in immunocompromised patients. Symptoms: extreme local pain, pain out of proportion. Edema, swelling. Blisters, skin detachment. Bluish-black bleeding, skin hematomas. Superficial, cutaneous anesthesia, due to involvement of the nerves. Crepitation, due to gas formation. Fever.
Diagnosis, clinical examination. Laboratory rising leukocytes. CRP, procalcitonin, creatine kinase. Note, soft and skin tissue infection plus rising in CRP plus rising in creatine kinase. In 80% of cases, it is highly suspicion of necrotizing fasciitis. LRINEC score. Imaging. Sonography, linear transducer. Hypoechoic seam over the fascia, feathering of the muscles. Staph, mnemonic. Subcutaneous thickening, air, fascial fluid. Tip: always compare your finding with the contralateral, healthy side. CT, native sufficient, no contrast agent required. Most quickly available. MRI, best. If necessary, biopsy should be performed generously in unclear cases with subsequent immediate frozen section examination in pathology. Therapy: antibiotics, combination therapy of piperacillin, 4 grams, tazobactam, 0.5 grams 3 times daily intravenous route plus. Clindamycin, 900 milligrams 3 times daily intravenous route. Equivalent alternative: linezolid, 600 milligrams twice daily intravenous route plus. Penicillin G, 10 million units, 6 times daily intravenous route. Surgical, radical necrosectomy, if necessary amputation as ultima ratio, life before limb. Note, in case of doubt always surgical exploration.
Fournier gangrene. Special form of necrotizing fasciitis. Necrotizing fasciitis of the pelvic fascia. Named after the French physician Jean-Alfred Fournier, 1832 to 1914. especially men, genital area, especially in diabetes, mellitus, or alcohol abuse, especially after urological surgery. Increased risk with sodium glucose transporter. 2 inhibitors increase glucosuria, especially if genital hygiene is inadequate. Therapy. Antibiotics. Combination therapy of piperacillin, 4 grams, just sheet tazobactam, 0.5 grams, 3 times daily intravenous route plus clindamycin, 900 milligrams, 3 times daily intravenous route. Equivalent alternative, linezolid, 600 milligrams, twice daily intravenous route plus penicillin G, 10 million units, 6 times daily intravenous route. Immediate surgery, possibly hyperbaric oxygen therapy. Gas gangrene. Definition, infection by Clostridia, gram-positive anaerobic spore formers. Clostridium perfringens. Clostridium histolyticum. Clostridium septicum, mortality, 50%. Symptoms, extreme pain in the area of the wound. Skin emphysema, crepitation, crackling. Drainages after surgery, bloody, foamy, foul-smelling secretion, mostly full picture of sepsis or even septic shock. Diagnosis, clinical examination, laboratory, imaging X-ray, feathering of the musculature, CT, MRI, swab, microbiological pathogen detection, therapy, antibiotics, combination therapy of piperacillin, 4 grams, tazobactam, 0.5 grams, 3 times daily intravenous route plus. Clindamycin, 900 milligrams, 3 times daily intravenous route. Equivalent alternative, linezolid, 600 milligrams, twice daily intravenous route plus. Penicillin G, 10 million units, 6 times daily intravenous route. HBO, hyperbaric oxygenation. Surgical, debridement, amputation. Thank you for watching. If you found this presentation helpful, please like, share, and subscribe to the Critical Care Code channel for more intensive care education.